Yeah, so good evening, everyone, once again, and welcome to this session. Today, we are celebrating World Suicide Prevention Day. And as part of our team at Rahat, we felt it is very important for us to, and that's what we've been doing last couple of months. We've been bringing about awareness in different areas of mental health because we feel that that is one area which is kind of neglected, not spoken about. Even if we talk about it, there is a lot more that we can kind of bring about awareness. Um, I'm Dr. Vinita Mathew. I'm a family physician, and I have a passion for bringing about awareness in this field of mental health because I myself have been through mental health challenges many years back. And I realized that if it wasn't for people who had reached out to me and, supported me, I wouldn't be where I am today. And I feel I want to bring the same thing to somebody else who's suffering mentally. Uh, so that's the reason why I've also started this organization called Rahat. It's part of um, our team. So we are a hospital in Mumbai, Daisar, Ashok and Ashok One Hospital, and part of that is Rahat. That is, we focus more on the mental health aspect. And today we have with us Dr. Suraj Singh, who is also part of the Rahat team, and he's a psychiatrist and he consults with us. So I'm so glad that he had agreed to speak about this topic. So today's topic is on suicide, how to the risk of suicide, especially in patients who have mood disorders. So we'll talk about more about mood disorders and then how that those uh, patients have an increased risk of suicide, and we'll talk on suicide in general also. So, welcome, Dr. Suraj. And if you can just give us a brief about yourself, that will be better if you introduce yourself.
Thank you so much, ma'am, for giving me this opportunity. Hello, everybody. I am Dr. Suraj Singh. I'm a psychiatrist practicing in Mumbai. I've done my MD from KM. I've always felt like prior to joining psychiatry, also, I would feel why is there a need for a World Suicide Prevention Day? Even till day today, my family as well asked me, is there a day like this? So there is still a lack of awareness regarding this and regarding suicide and how mental health affects this. Ma'am's efforts at Rahat are really touching. The first time I had been there and I realized the counseling of each and every patient and understanding this holistic concept of health. So I do believe in this holistic concept of health, and mental health definitely plays a very important role.
Yes, thank you so much, Dr. Suraj. So, basically, at Rahat, and at the hospital, Ashok and Ashok One Hospital, we do take a psychosocial history of all our patients, though the patients don't get admitted for per se a psychiatric illness or those kind of things because it's a general hospital. But we believe that catering to the psychosocial aspect of the patient's health is very important because that is one area which is missed out. We ask about the signs, the symptoms, what the patient is going through, fever, all the other kinds of history we take as doctors. So that's a lack even with us doctors. I agree with that. And we very often, we either miss and we don't find it significant. But now more and more research is saying that the psychological health of the person affects and has a big effect on the physical health of the person. So if we miss that out, so psychosocial spiritual history is what we try to do when the patient gets admitted. And this Rahat is more for outpatient, catering to the outpatient uh, outpatients, and those who come for OPDs. And so that's the reason. And we want to bring about awareness because we know that awareness is lacking in this area. There are a lot of misconceptions. Okay, so today's topic is, basically asking, are you okay? So, do we ask this question? And when somebody asks us that question, do we answer it honestly? Okay, so we want to bring about hope in people's lives. And that's the reason why we are talking about this today. So recognizing the signs, the warning signs, creating safe spaces, and also if somebody has attempted suicide, like if you know somebody, how will you be able to support that person is what we're looking at. We want to say that nobody is alone. We are here, and at Rahat, we want to be your support. So we'll just look today basically at low moods and suicidal thoughts. So how are they related? So Dr. Suraj has given me three case studies. I wouldn't want to call it case studies. I would like to call it patient stories because that's how we would like to. Because each one, this is a story, somebody's story. It's a real life story, and they've been through certain challenges. And as Dr. Suraj has walked through with them, he will explain more details about it. So I will first give you a brief about the patient's history, and then the patient's history, through that we'll ask some questions, we'll like have a dialogue, and at the end of it, if I request all of you all, if you all have any questions, please keep putting it on the chat box, because we'll take the questions at the end so that the flow of the entire session will not get disconnected. Just a minute. I'm just getting a phone call. Can you just give me a minute? Sorry, I'm just. Okay, so we'll just go to the first patient story. So this is a for 42-year-old male. He was actually he came to the ICU consuming tablets, the clonazepam tablets, and 5 tablets of another medicine which is given for psychiatric illness. And his history basically revealed that he had a known case of psychiatric illness. He was previously treated with antidepressants. Sometimes he would discontinue medications, and then after he felt some improvement, he would stop it. So and he was residing in this in a UAE country. Basically, his treatment was unsupervised. So, Dr. Suraj, I want to ask you this question. You noticed that there were erratic medication, like basically was not compliant, and whenever he felt a slight improvement, he would stop his medicines. So,
Yes.
can you just give us a brief on what do feel about these kind of patterns? Is this common? And can you just give us a little bit about mood disorders? Maybe just share a brief about
Hmm.
what do you mean by mood disorders?
Okay, sure. So yes, ma'am, coming to your query, firstly, yes, we do see a lot of patients. So they stop medications. Initially, if they start feeling a little better, they stop the medications. There are many factors responsible for it. One is the stigma and the myths associated with it. So many of them already feel that they do not need any medicines, especially for the mind. So continuing them for a long time, they have this misconception that they will get dependent on it. Along with it, the role of family members, relatives, friends also, they always keep telling them to stop the medicines. You don't need these medicines, right? There's another barrier, the chemist as well. So many of the chemists, pharmacists, they properly are not pharmacists. So the salespeople, they as well keep telling them that do not take these, will not give these medicines. These are very risky and all those things. So I think all of these factors combined, the patient already has a bit of doubts in their mind. So if they start feeling slightly better, they are able to function, they stop it. uh, and mood disorders, yes, on a broader aspect, mood disorders contain things like depression, if people here are aware. So major depressive disorder, which we call it, which consists of this persistent sadness of mood. So there's a sadness of mood which stays for a longer time, so for a period of at least 14 days, and it's present throughout the day. There's these feelings of not feeling joy when there are things which usually bring joy. For example, spending time with family, going out, eating something good. So these things which bring joy to a normal person, they do not bring any joy to these patients. And we call this as anhedonia, this symptom. There can be also some biological functions disturbances like sleep disturbances. So they cannot have good sleep. They'll wake up early or wake up in the middle of night. There can be loss of appetite as well. Along with this, yes, there can be suicidal ideation. So there can be thoughts of ending their life. There can be thoughts of life is not worth living. So major depressive disorder is one aspect of mood disorder. There's another part of it which we call as bipolar disorder. So very easily, as we explain to patients in Hindi, it's like kabhi khushi kabhi gum. So it's two aspects of a pole, opposite sides of a pole. So one is depression, which we've seen. The other is mania, where they have a constant high mood. They feel very happy, very elated. There's a lot of activities done, and sometimes it can cause this to them. Like they can go and spend a lot of money. They can indulge in certain substances like alcohol and other. They can indulge in risky behaviors like rash driving or promiscuous relationships outside. So bipolar also is a part of the mood disorder. Uh, Going ahead, we'll also see certain other aspects like personality disorders. So what those comprise of, we'll go ahead as we discuss.
Sure, sure, sure. Yeah, thank you. So basically, what I understood from the case, this person's story is that he was like basically the reason why he took an overdose is because he was attempting to sleep peacefully. That is what you had mentioned in your, story. So, from a clinical perspective,
Mm.
how can you, as a psychiatrist, or you, for that matter, even a family member, differentiate whether this is an impulsive act or it was a genuine suicide attempt? Like, how do we distinguish it as a person, as a supporter, of the person?
Correct, ma'am. So yes, this patient, he actually told me that he just wanted to sleep peacefully, that he didn't think much whether he wants to end his life or whatever. He just wanted to sleep and slightly felt better, then stopped medicine. So he somehow he said that he wants to feel better. So distinguishing, yes, sometimes it can be tricky to distinguish an impulsive act as well as a planned or a suicidal act. So usually, if a patient is suicidal, there are certain warning signs we have to observe. So they can appear withdrawn. They can start not talking with the family members. If a usual person's behavior is very talkative, enjoying, and they suddenly change, they start being withdrawn.
Mm-hmm.
Another warning signs are if they leave any letter or they start sharing of their belongings. They don't start keeping any of their things, so they start mentally preparing that yes, they have to go. Impulsive attempts, yes, but we also have to consider that every impulsive attempt can also be risky. It can be lethal at times. So we have to take that with severity as well. That if it is an impulsive attempt, that is also a suicidal attempt. So in our teaching, we say that every suicidal attempt is a cry for help. So irrespective of the attempt, we have to consider the seriousness.
Yes, 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 definitely. That's very true. So, since this person was living abroad, like he was in the UAE for many years, and his treatment was unsupervised, so what do you think is something? Sorry. What do you think is something that, the family members or the friends, anybody can, like, some safeguards? What do you feel that some safeguards that we can keep in
Right.
mind?
So, ma'am, if a family member can stay with the person or a relative, we can ask them to keep a supervision on the medications, on his treatment. Sometimes there have also been cases where I have discussed with the treating doctor there, the consultant psychiatrist or the psychologist as to how the person's condition is. In certain countries, like in United Kingdom, in US, they also have the concept of community social workers or
Right.
community psychiatric nurses.
Hmm.
So they can go to the person's house, they do supervision, they observe them, and they give the medicines to them daily, observe their mental health condition, and they also, the patients are required to participate in activities, community activities, or be a regular visit to the hospital. So basically, we have to remember not to give a long-term treatment without supervising the patient. And if a family member can be present, they can also, their role also is very vital.
Yes, very true. Yeah, I think such kind of people without a good supportive system, it's difficult to manage them, right? A good support system is important for such kind of a person, right?
Yeah.
Yeah, thank you.
Yes, ma'am.
Is there anything else, Dr. Suraj, you
Yes,
want
ma'am.
to share
Social
about
skills is
this
very.
particular? Am I audible? Is my audio okay? Okay. So is there
Yeah. Yes,
anything
ma'am.
else that you would like to share about this particular person, how you managed him, or like, what were some of the things that you kind of did so that you could help this particular person?
Yes, ma'am. So initially, I evaluated him on a detailed history and the mental status examination which we have. On doing that, I understood that about his intent, his ideations. Had he ever had this previously, or were there any planning for this? Was he having suicidal thoughts previously? As that alone adds to a major risk factor. I also tried to change his medicines a bit. So along with antidepressant, I added a mood stabilizer, which we call it as mood stabilizer, to helps to stabilize the mood as well as reduce suicidal ideations. Since sleep was a major concern for him, I added something for his sleep for a short term duration. And since he was here with his family, I informed the family which medicines are to be given when. I also particularly informed his wife to monitor on his sleep, and a regular 7 to 8 hours of sleep cycle is very vital for him. The other aspect I informed them is that it is we have to take this seriously. Initially, the family was reluctant to meet a psychiatrist, but since it was an ICU admission, and fortunately, it is compulsory for an overdose to for a psychiatric assessment. So once they met, I told them the his intention, how severe this was, and if we do not want to repeat it, how we have to get it better. To the patient also, I have explained that along with medicines, if he ever gets these ideations, to talk to his family or to talk to me, and he has to keep a good check on his sleep, on his daily routine, whatever work he does, if he's working, to keep a proper routine about that, those things. I explained to him the need for compliance since he's always been erratic. I told him if he has to get better, has to come out of this, so he has to take medicines regularly. And once he's better, he and his family and the doctor together will take a call on reducing the medicines gradually, or as therapy as required. So he did agree to that, and he did take this attempt seriously. So now it's been a couple of years, and he's been doing good.
Great, great. Wow. So he's doing well now. This is a couple of years back, is it?
Yes, ma'am.
Okay. And did you find that he needed, I mean, did he attempt anything like that again?
No, ma'am. So after that, there was no suicidal attempts, no thoughts as well. He's doing
Oh,
quite fine.
great. That's very encouraging to hear. So, I mean, so it's so important for us to have again, a holistic way of treating the person.
Yes.
Yeah. So, yes, yes. Okay. So, the next patient story which you have shared with me is about a 21-year-old female who was referred because she had multiple superficial cuts on her forearms. There were frequent crying spells, and she was repeatedly getting into quarrels with her family.
Mm.
Right.
Yeah.
So I wanted to ask you about this person. Um, so it looks like there are some self-harming behaviors, but it is not so deep enough that,
Mm.
would uh, cause them to actually their life to be ended. So how do you kind of handle such things? Why do they such kind of people resort to self harm? What is this particular diagnosis also? If you can tell us that, because that also comes under some form of a personality disorder. So if you can just share a bit about this particular person also.
So, ma'am, on detailed inquiry with her history taking and examination, I also found out that previously, apart from cutting, she's also had history of ingesting tablets. So, simple tablets like paracetamol, but in overdose, like 5 to 6, where she knew it could not be very fatal, but she has done that. She's also reported feelings of emptiness. So, she says that she feels a sense of emptiness. She feels abandoned, so that her family members will leave her. Nobody will be there with her. She's had relationships, but these have also been very short, intense. A lot of quarrels during that as well. There were a history of domestic violence, so a lot of issues at home. So she's been seeing that as she's been growing up. She reported that she didn't have any actual wish to die, but these things which she did, cutting herself superficially or overdosing, this brought a sense of relief to her. So maybe she didn't understand during that time as her emotions was very high. So how to deal with the emotions? She would resort to this, and after doing that, she would get a sense of pain, and then she would start feeling better. So she said that this was her way of coping to her surroundings, to her situation. So these symptoms which we see quite frequently, so we diagnose it as a borderline personality disorder. The term now has also been replaced to emotionally unstable personality disorder. So they have a lot of emotional changes. They can have mood lability, we call mood fluctuations, intense emotions. They can feel sad for a while, then suddenly they'll feel good, but a lot of mood changes which they'll experience.
Okay, okay. So, like when a person does such kind of a thing, does it, I mean, sometimes people say, oh, this person is just fooling around. They're not really serious about it. So, what is your take as a clinician? What would you say to a family member
Hmm.
who has, like this kind of a person in their family? How would they like, sometimes you say, no, crying wolf, wolf, and you don't, at the end, there's really a wolf and you don't go for it. So, what can you say about it as a clinician?
Correct. So yes, ma'am, we do see this frequently, especially family members or their partners, if they are there, that this they are just threatening, they will not do anything. But I've explained to them that every attempt has to be taken seriously, since we never know how the person's state of mind would be. One cut, if it goes deeper, or the tablets get excessive, and there has can always be a risk of harm. So every attempt, of course, has to be taken with utmost severity. I explained to them not to joke around with this, or not to threaten the other person or the patient specifically, that you just keep threatening you will not do something like this. So a lot of care and compassion towards the patient. I also explained that these people who do this, they are not doing it purposely. This is because there is interpersonal issues, their emotions are not controlled, or they are not in the right place. Their emotions are here and there. So that's why, to feel better, they do this. And once we teach them, we will teach them good coping skills, how to manage their emotions better. So these attempts will automatically reduce. But the family member support is very essential and vital, especially during these times. So one important is not blaming them if they do something like this, not shaming them or blaming them that, see, you have all these scars, how do you look like this, and what will people think if all this keeps happening, who will marry you? All these things are to avoid telling them. Rather, just simple words like, what happened, how are you feeling today, what were you feeling when this happened, what were your thoughts? Simple tactics like this, or just telling them that yes, you are not alone, we are here to understand, we can deal with this better. This involves risky behavior. Just small techniques which they can use.
Yes, yes. Thank you, thank you. Okay, so what is the role like counseling, psychotherapy? How can that help a person who going through such kind of symptoms?
So counseling, psychotherapy is very important for these conditions. One specific kind of therapy, which is the dialectical behavioral therapy, we call it as DBT. This is vital along with psychiatric medications. Counseling plays a very important role. So what it does is it teaches the person how to regulate their emotions. So during the periods of self-harm, when they have these intense emotions, we teach them how they can manage these emotions better, how they can tolerate this distress. So whatever thing worries them, whatever thing bothers them, For example, it is anger or a lot of hurt. So how they can acknowledge those feelings, accept those feelings, understand that these are just feelings, and how deal with it better. They also have a lot of relationship issues where they have abandonment issues. We try to dwell into their past, any childhood traumas, any growing up, any traumas which they have, and how to let go of those things. So most vital is to understand their emotions and control it better, so that they do not resort to these techniques to feel better.
Thank you so much. Yeah, that's really helpful. Yeah.
Yeah.
And so we'll go to the next story. That's about a 29-year-old single businessman. He presented to your OPD with persistent sadness, crying spells, hopelessness, helplessness, feeling guilt, worthless.
Mm,
He had also disturbed sleep and
mm,
suicidal ideations for the past 2 months. And I think his difficulties were compounded with some interpersonal and financial stressors. And I think you mentioned that he was also started consuming alcohol regularly, right? So in this particular person, since alcohol is also now involved because he's like taking substance, he's abusing substance also.
mm.
Um, so can you explain the relationship between like, it's not just alcohol, but nowadays I think people are using other, substances like weed and those kind of things. So can you just explain the relationship between alcohol use, depression, and why this is such a dangerous combination in context of suicide?
Correct. Yes. So yes, ma'am. On inquiry, I found out that his alcohol use had started and it had increased quite a lot to around 3 quarters per day. And he reported that he would not sleep if he did not consume alcohol. And on the next day, he would feel worse. So he would feel low. The depressive symptoms would flare up. And one instance was there when he was under the influence of alcohol and he took multiple tablets. And he said that he wanted to die, so he took that, but after doing that, he felt a little uneasy, so he vomited out and fell asleep. The next morning is when he realized that now the condition is quite severe, and then he came to seek help. So here we do keep a dual diagnosis of major depressive disorder and the alcohol use disorder. Like you said, the other substances as well. We see a lot of people using cannabis or nicotine to cope better. How this starts is because of the stigma associated, because of the shame associated, or sometimes lack of awareness. A person doesn't realize that they are going through depression or they should seek help. But alcohol is easily available with friends, socially accepted, so they start using it. Initially, the alcohol makes them feel better. For the time being, when they are intoxicated, they forget their symptoms. Slightly, they sleep better. The anxiety goes down, and so the craving for alcohol starts. And in this way, they use it as a medicine. They feel that it's working as a medicine, but what they fail to realize is on the next day, once the alcohol effects wear down, the withdrawal effects start and the symptoms get worse. Because alcohol as well affects all the neurochemicals, it depletes our dopamine, it depletes our serotonin. And a person with depression who already has less of chemicals in the brain, so the neurochemicals, so this causes a further decrease in their chemicals, and it increases the severity of their depression. So instead of getting better or feeling better, they tend to get worse. So yes.
Yeah, thank you. That is very helpful because I feel even this alcohol, consuming alcohol for sleep, that is also another big myth where people think that they'll get a good sleep, but actually it really messes up their sleep cycle. Yeah. So another thing about this particular person was that I think you mentioned that he also tried to double it with some consuming some tablets, right? Because he was not able to sleep with alcohol, something of that sort. So how did how does that also, combine this decision making ability
Correct.
under the influence of alcohol?
Yes, ma'am. So we usually see the decision-making skills or the cognition, which we call, gets a lot of impairment with alcohol. We have heard cases where people drive under influence and they undergo accidents because your brain or mind does not work that well. So this is a major risk factor. Since with depression, the suicidal ideations are mostly there. So with alcohol, those ideations tend to increase, and the control which we have, a part of the brain which tells to control, that goes down, the inhibitions go down, the fear goes down that maybe this something will happen to me or this is not right. So the risk tends to increase. Also the lethality can increase if a person is in not under influence, is not taking substance. Maybe he will not take such a lethal step, but if under the influence of alcohol, they will not understand that this amount of substance or this substance is very lethal or it is very harmful to my body. And so the risk definitely increases a lot.
Yeah, very true. Yeah. So, like in this case, because the insight is lost when you
Hmm.
consume alcohol. So, what are some key steps that you would recommend to take, like either long term or immediate steps and long term steps that to prevent such things? Because now they, along with depression, they also become dependent on alcohol. So it's like a two things are happening simultaneously. So, how would you recommend that to be?
Correct. So the immediate is, ma'am, supporting him, counseling him for depression, which we call it as the CBT, as well as for alcohol. Both have to go simultaneously. We call a technique which is motivational enhancement or brief intervention, where we can just talk about how alcohol has harmed him, what are the side effects of alcohol. Rather than us telling, we ask the patient usually how they feel alcohol has caused them damage. So in telling us, in talking to us, it brings about awareness in them as well how alcohol has damaged them. So a brief counseling for that, and appropriate medications for improving his mood, as well as for reducing his cravings for the substance and improving the sleep. We also tend to explain this effect, how alcohol has initial euphoric, which is feeling good effect, and how later it causes you to feel worse. So the first step for you is to just stop this substance. Whatever help you need, there are people around. You can ask family, you can ask us, but stopping substance so that you come out of the depression faster. Immediate measures are this. Long-term measures, of course, is involving the family members. Like many people know about support groups, so alcohol has a Alcoholic Anonymous, where they usually conduct meetings every Sundays free of cost, where past people who have used alcohol, who have been dependent on alcohol, they share their stories, how they have quit alcohol, how they are doing well. So hearing all of this makes a person feel that no, they are not alone. There are other people who have come out of it, who have gotten better. So they also tend to understand it. They try to implement them in their life and gradually start feeling better. Since there is a lot of shame associated with this, that people tend to feel, I'm consuming this, I'm bad, there's no hope left for me. So hearing from other people who have been in similar or worse situations and they're getting better. A long-term plan is relapse prevention, so that a person doesn't slip back into alcohol, as well as for treating the depression so that his mood also simultaneously improves.
Wow, great. That's really helpful. Very helpful. Like you've covered a lot of things. So, just to brief our participants, these are some statistics that we have on bipolar disorders and the major depressive, depression. The ideation. Like usually, people think that only those who are depressed will have these kind of things. So, that is what we have seen that attempts of suicide in people with bipolar is much more than people with only depression. So that's why it's important for the diagnosis to be correct, the treatment to happen as per the diagnosis, and then the continuation. And I think, like Dr. Suraj said, the support that the person needs is huge. Like so, it's important to understand the warning signs, the what are the cues, like Dr. Suraj already shared some cues that you see that the person is sudden unusually quiet, or they are giving away their belongings, saying that I don't need it anymore. So these are some of the behavior cues and warning signs that you should kind of think of, suspect. And the role of family, of course, faith, a good community, and the immediate steps that are taken to, to see that the person who is at risk is given the treatment or the referrals that are needed, and keeping handy the referral pathways, the helplines, whatever is needed. So these are some statistics like which we, all of you must keep in mind, when you're looking at this. And one more question I had, Dr. Suraj, sometimes people say that a person whom you suspect to have, a suicidal tendency, it's better not to broach the topic, otherwise they may actually go ahead and do it. So
Correct.
what is your view on that?
So yes, ma'am, this is a very common misconception people have that if we ask somebody, even if they're not feeling like it, maybe we are putting that thought in their mind. But it's the opposite of this. So there have been research, there have been studies proven that in fact, if we ask them, they tend to feel heard, they tend to feel supported. So if they have some ideas, they may express it, and they understand that they have somebody for support, for help. So the tendency to commit suicide actually reduces if we ask the question. Yes.
Okay, great.
Yeah.
Thank you so much. So, can you now tell us something like a difference between suicidal ideation and suicidal behavior?
Hmm.
What is the difference? Like, one is ideation, one is behavior. Like, how do you differentiate the
Yes.
two?
Hmm. Okay. Hmm. Yes, ma'am. So suicidal ideations, usually it can be of two types. It can be active or passive. Active, when the person actively feels like he should do something to not live anymore, to die. So there may be thoughts, planning. He may have bought certain things, or he may have researched about the behavior. Passive suicidal ideations, which we very commonly see in depression, there the person just feels that life is not worth living. What is the point of living like this? Those things, but they may not attempt actively. In suicidal behavior, like we discussed in the start, so they can start researching about things, they can start buying things which can cause this certain other tendency. They may start writing letters, they may start sending messages to people that bye, take care, or that ways we can differentiate ideation and behavior.
Okay, okay. So,
Hello.
you can hear me? Am I audible? Yeah.
Yes, ma'am.
So can you just give us a little more about the difference? There are some, I think Aaron Beck has given us a negative triad, uh, you know. So if you can
Hmm.
just share a little bit on that, I'll also share the slide. Can you just
Yes,
tell
ma'am.
us more about it? The components of a suicidal trait.
Yes, ma'am. So,
Yeah.
Ehrenbeck, as most of us must be knowing, is a famous psychologist who brought in the concept of CBT, or behavioral cognitive building therapy. So he describes suicidal ideation as this triad. So a negative triad consists of a negative view of self. So what the individual or the person patient feels that they are flawed, they are not good. They may say that life they are worthless. Okay, they may express thoughts like I am a failure, I am not good enough, or I am inadequate, right? So first is negative view of self, second is the negative view of the world, where the person believes that their environment, the place where they are in, their surroundings is not supportive, it's hostile, it's not good. So then they can express thoughts like no one values me, this world is an unfair place, it's not a good place to live, there's so many bad things happening, things like that. And the third, which we call the most risk factor, is the third factor, third thought which they express is negative view of the future. So when the person says that their situation will just be like this, there is no hope left for them, so we express it as ideas of hopelessness, that I will never get better, I will always remain a failure, I can never improve, or I can never come out of it. So hopelessness, if they express, is considered a very major risk factor for a suicide attempt. These thoughts are sometimes called as automatic thoughts. So when a person undergoes depression, or they are facing mental health issues, these thoughts tend to increase negative views about self, environment, or future. And therapy thus plays an important role in addressing each of these thoughts, challenging these thoughts, how to change these thoughts, etc.
Great. Yeah. So, can you share some, you may be having some stories of people who have really come out, like it was diagnosed at the right time,
Hmm.
and the people who are, and if you can share also the other side, the flip side, if
Hmm.
you can just share the one who was not diagnosed well. So, can you just give us some of your
Yeah.
experiences?
Since okay. Hmm. I've worked at government hospitals also previously. So since the referral is mandatory for any suicidal attempt to a psychiatrist, so we've seen a lot of cases with impulsive attempts, maybe trying to consume tablets or even trying to hang themselves, mostly with females, adolescent females or early young adults females. So timely intervention has helped them, then explaining the family members how they can cope better and how to avoid these situations. Mostly, we understand the situations. We call it as antecedents as to what led the person behave like this. Why did they do that? So maybe if the situation repeats, how they can cope better. What different can the family members do? A lot of counseling of the person as well as the family. It has helped them. So the impulsive suicidal attempts, many have improved and have not attempted again. Then there have also been cases of depression which have expressed suicidal ideations, but since they have expressed to the family members or they have expressed to the doctor, and once they've started treatment, I've seen a lot of improvement in most of them. Flip side, yes, there are a few cases. We tend to read it also, ma'am, across so many platforms. So
Yeah.
recently we've heard that a teenager in US here was taking help from ChatGPT. So and it didn't. So patients and everybody has to be aware that these AI tools will not have that empathy or that understanding as to a professional or a mental health professional will do. So he understood the techniques, what all has to be done. That I have heard recently. We've also seen at colleges or students, especially when there's exam pressure or failure to clear an exam, how they tend to do it, and sometimes, unfortunately, it tends to be fatal attempts. So those are a few of my, in fact, medicos like doctor colleagues also have had certain family members do that because they had maybe missed the signs or maybe not that aware of another aspect which we get to deal with is, ma'am, the survivor's guilt. So if a family member or a person we know commits suicide, there's this tendency that I should have done better, or maybe I could have done something to save that person. Maybe he
Hmm.
galti, I was
Yeah.
bad. Those things we deal with.
Yeah. Yeah. I think the one who's left behind has a lot to, you know, they
Correct.
need to work on a lot then after that, right?
Yes, ma'am.
So, can you give us something like something that as a community, what can we do as a community? Like, something that in some way, how do we support a person?
Hmm. Hmm.
First and foremost, of course, awareness is required, but then suppose you come to know of it, how can the community help?
Hmm. Yeah. So, ma'am, we can look at this care framework which we follow. So,
Yeah.
is first is to connect to the person. So, build a trusting relationship. So, just simple, like you started the PPT with asking how you are doing. So, if we see a person not doing well, if we observe that the person has changed their behavior, you can just ask them and just listen. Sometimes the person may just need somebody to listen to them. So just listening to them, showing them empathy, just telling them that we are with you or you are not alone. We don't understand, but it plays a very major role. Then the second thing is to assess. So as family members, as as professionals, we can understand, but as a common community, yes, they can also ask the person about, are you having any suicidal thoughts, any plans, are you feeling like life is not worth living? Just simple questions that, have you thought of this before, or were there any thoughts like this? So this they can understand the level of risk, if there is any risk for the suicidal attempts. The third step which we have in the care framework is assist. So if the person we have maybe the person is not in a mental state to understand how to go ahead or what help to take, so we can involve the family member. If we it's a random acquaintance or a workplace colleague, we can take the role of informing their family members. There's also a lot of helplines now, ma'am. So we have Telemanas, which is the national Indian initiative for teleconsultation. So emergency numbers for medical students, there has been started one. For teenagers, there are one. So we can immediately call the helplines or ask we can dial the number and give the person to talk. Sometimes just speaking 2 to 5 minutes can help them. If we feel that no, the risk is quite severe, informing the family members, maybe considering the patient to get admitted to a center, not necessarily a psychiatric center, to a general hospital as well, where a psychiatrist or a mental health professional can visit them.
Hmm.
Uh, Next step is we can reassure them, that to offer them hope, to tell them that you are not alone into this. We are with you. We understand your feelings. At times, a person just needs validation for their feelings. So if they are feeling this way, there's already a lot of stress, shame surrounding it. Just telling them that it's okay to feel like this, but we are there for you, also plays a very important role. And last is to encourage them. So once we feel that their mental health is getting better, they are participated in some mental health care. So are they visiting a psychiatrist or a psychologist? So just to make sure that they are continuing that this, are they learning healthy coping strategies? So if there is if the surrounding is bad, if can they change the surrounding? If they are feeling bad, can they change their self, or cope with these feelings better? So understanding those techniques also.
Great. That's
Mm.
very helpful. I think the most important aspect is, listening to them without causing any form of stigma or, judgment upon them. I think that is a very crucial thing for them.
Many a times,
Yes.
ma'am, people tend to minuscule them. So if somebody says I'm suicidal or these thoughts, people tend to tell them, "Arey, what less you have? You have everything in life. How can you be like this? Why are you so ungrateful? Or why are you being coward?" These lines actually tend to worsen the
Correct.
situation. Uh,
Very true. Very true. Yeah, I think advice is the last thing we need to give them. Yeah, yeah. So, yeah, I think those were some of the questions that I had for you, Dr. Suraj, but I think definitely our participants will also have some questions. So, right, I'll just now allow the participants to have a time of Q&A. Yeah, I think we've already got a person raise their hand. Sunita, I think, has raised their
Yeah.
hand. Yeah, yes, go ahead.
Yeah. So, doctor, I lost a friend to suicide around 2 years back. She was undergoing through treatment for depression, and this, as you said, family support was not so much, but as friends, there were many people who were there along with her. She even took electric shock treatments and things like that, for her to do it. But after 2 years of still going through it, she just took rat poison and killed herself. So that was a real shock, and also for us, as you said, survivors, like we were feeling that what more we could have done, to just help her and support her, to in such cases, what can be done if we miss out. Then there was another family who was also manic and bipolar, as you said. So the children were suffering. As friends, we tried to help. The mother was suicidal, things. So again, very difficult. They didn't want to go for a psychiatric treatment because of the stigma that is attached. And just 2 days back, we lost another family friend who committed suicide, and it was a shock. There was no symptoms, or as you said, we missed symptoms that were there. So, what are the things that we should look out actually as symptoms, and how do you cope with when you feel inadequate, we are not being able to reach out and help them?
Okay. So, yes, so unfortunately, in 1% cases, we cannot predict, even if on treatment, yes,
Mm.
certain can take these steps. So, warning signs are yes, like we've discussed, to watch for any changes in their behavior. Are they behaving differently, like how they were? Is there any ongoing stressors with them? So, is there anything particular bothering them, be it their workplace or home? Any major
Mm,
changes? Sometimes changes, losses, grief can cause people to affect this. So, if rather than we can just keep asking them, or how is life going, or what are the things going
mm,
on. For the guilt management, for the survivor's guilt, yes, that also the people also might have to undergo a few sessions of therapy. So grief counseling, which
mm,
we call, which is very helpful, just to understand that maybe we've done our best, whatever we have done, our role has been done, and now there was nothing beyond this which we could have done. So just understanding that, just accepting that. Firstly, is to identify that yes, we are having these feelings, and it's okay to experience these feelings, because
mm.
sometimes we tend to stop these feelings. We tend to feel worse, that why am I feeling like this is
Right.
not. We keep blaming ourselves that maybe I should have done more, I should have done
Mm,
this. So to stop blaming ourselves as well, we need to have that compassion, empathy towards ourselves
mm,
also, which we and express
mm,
towards others. And then just trying to accept it. Of course, that loss will always be there, and we have to accept it, that okay, yes, this has happened, but this was all I could have done, or maybe I will remember it next time if there is other things I can improvise on. But
right.
if we
Okay.
keep dwelling on it, yes, our health can also tend to be bad.
Okay. Thank you, doctor. Thank you so much.
So we have a few on the chat box also.
Hmm.
Uh, how should we counsel a 24-year-old married woman with schizophrenia on treatment regarding conception and pregnancy, considering medication, safety, and the risk of suicidality in the perinatal uh, period?
Okay, yeah, this is a good query, ma'am. So, especially with female patients, yes, already having the mental illness causes them stigma, then marriage issues, and then pregnancy, conceiving issues. So, usually what we do is we explain to them in stats. So, we tell them that out of 100 patients, if we use, maybe one can develop certain side effects, but the ratio is very less. So, 1 in 100 is almost negligible for this. Your baby can be continuously monitored with new USGs and techniques. So continuous monitoring will be there. There are medications which are completely safe to be can be used in antenatal pregnancy period. They are free from teratogenic side effects. So explaining to them the stats about how they can be monitored, explaining to them the beneficial effects of medicine. So a risk to harm ratio is what we explain. So how medicines taking will be beneficial, and not taking them how harmful it can be, because pregnancy itself causes a lot of hormonal changes in the female, so can cause worsening of psychosis, especially in the peripartum postpartum period. So if that tends to happen, if there is a relapse of psychosis, it can be a risk of harm to self as well as to the baby. So they can there have been instances of infanticide, feticide because of psychosis. So we tend to tell them in such a way कि you can cause more harm if you do not take treatment. So rather you take treatment and we can monitor the side effects.
Yeah, thank you so much. Um, Another question is, how do we make people more open-minded about mental health issues so that they can become more supportive and not judgmental? Usually, middle-class society doesn't understand how depression and anxiety can affect their children in different ways, and they realize it before it's too late.
Correct.
Yeah.
This is a very common query, ma'am. Yes. So even before joining psychiatry, I've had these queries. So what I feel is we can do our part is by sharing these mental health, whatever we come through, maybe a few quotes. If we can spread awareness into that, we as mental health professionals, we play a good role. So we go to schools, we have meet with counselors, take lectures there along with parents, especially with this adolescent or early college going. So nowadays it's become mandatory also in certain schools and colleges to attend this session. So this tends to increase awareness. Along that, when we see these news articles of mental health issues or certain things happening, we can even share those with the family if we feel that they are not this aware. I think just doing our part, whatever we can to spread awareness, and gradually it will come around. At least even if the family doesn't understand, if a person understands a young child or a kid, maybe they can seek help whenever they go through it.
Yeah. True. I think awareness, awareness, awareness. That's that's what we need to bring about. Talk about it. I think we just need
Hmm.
to be talking about it. Yeah. Uh, so there's another one is how do you help someone whose family member committed suicide recently?
Hmm. Okay, this is a very good doubt, ma'am. So if because people tend to not understand what to speak during that time, or there's a worry, may I say something wrong? So most important is to just be there, to just listen. If they keep telling, if even if they cry in front of you, be non-judgmental, just be supportive. And maybe we are afraid that we may say the wrong things, like the person is still here, or there sometimes the relatives, the family member can even have certain like a hallucination kind of thing, that I can still sense that person, I can see him, hear him. So we have to be normal, because in the initial periods of grief this can happen. So we have to just be supportive and just agree with the person, not to tend to negate their emotions. I think only just doing that much is also sufficient. Mm.
Yes, very true. Very true. There's another question I've observed low moods pre-periods. That means for 2 days every month. On sharing this with my friend, I came to know that she also has the same problem. Without any significant problems, sadness is felt and sometimes feel like crying. So at
Correct.
that time, I feel more sensitive. Any suggestions for help? So this is more personal, yeah. But if you feel that this is something is common and you can maybe just give a small.
This is quite common now. In fact, our guidelines, the DSM, which we call, have added this also. So it's called as premenstrual dysphoric disorder, PMDD, or commonly people call it as PMS, premenstrual symptoms. So prior to the periods, maybe a week for some people to 2 to 4 days. What happens because of the hormonal changes? There is sudden changes in your hormones. Mood tends to change. You can feel low, irritable, can feel anxious as well. What can be done during these periods is certain natural remedies like magnesium helps. If there is any favorite food of yours, dark chocolate tends to help. Good fluid intake tends to help during those times. Naturally, we can tell our family members that, during this time I experienced this. So I want to be alone, or I do not want to talk much. Still, if all these measures do not help, we can consider a short course of treatment, so therapy or medication. Medication are specifically given only 1 week prior to the menstrual period and stopped after the menstrual period. So even those techniques help. One important factor is to know that this is not just happening with me, it's very common. And since they have diagnosed it now, they have introduced it in the guidelines. So it is a common condition.
Thank you so much. That's helpful. Another thing, some actually two people have asked about schizophrenia. So I wanted to just say that we had another talk on schizophrenia just last month. So these questions which are here, I'll read out the questions, but you will get your answers in the other talk. But so I'll just read it. Could you explain about schizophrenia symptoms and treatment? Is it hereditary? That's one. And the second, another question is we counsel a 24-year-old married woman with schizophrenia treatment regarding, I think, okay, I think this was
No,
already,
that is it.
that
Yeah,
was done.
taken.
Yeah, that was taken. So this regarding schizophrenia symptoms and is it hereditary, the entire talk is done before. But Dr. Suraj, if you can just tell us the difference between schizophrenia and the bipolar, the mood disorders, if you can give that distinction, it will be helpful because this talk is particularly about mood disorders. So if you can give that differentiation.
Okay. So in schizophrenia, like when I said, it's been discussed in details, but the symptoms tend to be more from detachment from reality. So when the person starts to behave away from realities, they can experience hallucinations, they can hear voices, they can maybe see things sometimes. There can be this strong sense of, paranoia, which we call that, somebody's trying to harm me, somebody can kill me, this fear into them. Apart from bipolar and plus the schizophrenia course is chronic. So the symptoms can almost always be there. With medicines, they can be controlled, but you will have a long-standing history. If we ask the family or members, it is a long-standing history. Stark difference in bipolar is it is episodic. So it is episodic. You have the symptoms for a certain period of time, take medications, they get completely better. So they can be better for years, and then there can be a relapse of symptoms. So this is a very stark difference even in the symptoms, since in bipolar, like I explained, the two poles, those kind of symptoms will be there, less of hallucinations or fear or those things.
Yeah. Yeah, so that is a main difference between the two. Yeah, that's very helpful. Thank you. So the person who asked about schizophrenia, we will share the other talk with you, so you can get all your questions answered in that. The other question here is a person with depressive bipolar. Stats show that persons with depressive bipolar are at a higher risk of suicide. In this case, is this the case even when the person is on medication?
Hmm. So yes, unfortunately, yes, the risk of suicide is higher in bipolar depression, since the depression tends to be for a longer period of time with atypical symptoms. The treatment also tends to be difficult. So the risk of suicide during the depressive period is higher, even with medications. That's why, at least in the initial period when the depression is severe, we ask the family to supervise the treatment and support.
Yes, yes, sure.
Yes.
Thank you. Yeah. So if there are no more questions, if anybody wants to unmute and ask a question also, that's great. We can answer that. I will share the link to the webinar, the schizophrenia webinar. If you all have registered, maybe we can send it to you by WhatsApp also.
Doctor, is mental health a disease that can be treated, right? Because sometimes people say, no, you just do some activities. You don't have to do this. You can just go for a walk, take a hobby or something. But the family members also, feel that if it's not a disease, it becomes an issue for them. That myth or something that can be countered.
Hmm, hmm. Correct. Yes, you are very right. So many people experience this. The family members are telling them. I tell them you do all those things along with the proper treatment, along with medications, counseling, therapy. You can do those things, but just doing those things will not help. So very easy examples we give of usually diabetes or a fracture. So if you have a fracture, you have to have a plaster. You can't just think. So similarly, having some mental health issues, disorders is like a fracture of your brain or mind. It needs rest, it needs proper treatment. So do those things as well, but take treatment also.
So I've posted the link to the YouTube channel, YouTube recording, and this will also be available on the same channel in some time. Okay, so sorry, what is the other one? Just wanted to ask about self-harm as a precursor to suicidal ideation or attempts, especially for suicide for students and adolescents or young children, young adults.
Correct. Yes. So yes, like we've discussed, yes, it can act as a precursor, because anytime we do not know how this attempt can turn lethal or how severe it can be or how the person's state of mind can be. So every attempt has to be taken with severity.
Yes, yes. And I think the same question is asked again is people say that those who threaten about suicide generally don't commit suicide. What do you say about that? I think
Yeah, we
it's the same
discussed it.
answer, I guess. Yeah. You want to
Yeah.
say something more, Dr. Suraj?
No, this I understand. There's this commonly seen with many people. So even many a times, even our patients' relatives say that so and so will not do this. I know them; they will not do this. We just tend to explain that none of us can predict when or how something can happen or how lethal a small attempt can be. So we have to take every attempt with severity, and especially not will not do anything kuch nahi karoge. So maybe even that they can take to heart and do something. Mm.
True, very true. The last, I think we can, after this, wind up. Usually, people, involved in sports don't get into depression. Is there a solution? Is this a solution for all mental illnesses? I think this seems to be a sports person.
No, no. So it's not the case. All we have so many people from sports, from other backgrounds as well. Yeah, definitely getting into a physical activity helps you feel better. So it helps in. It can be. We can consider it as a supplement to other treatment for the depression. But no, this is not the case that just being into that cures depression.
Yeah. I think it's a support. Definitely,
Support.
exercise is
Yes.
known to improve your mental health, but I
Mm.
feel that is not the only solution. It has to be a combination of many things, and it depends on from person to person. So
Correct.
it's not one size fits all. So that's what my take would be, and I think Dr. Suraj also would agree with that.
Yes.
Yeah.
Correct.
Yeah, I would love for all of you all to share your feedbacks on the feedback link that is given. We'll also share it with you all personally. And I would like to just take this time to thank Dr. Suraj. He has his busy OPD, but he's agreed to come and share whatever he
Mm.
knows, his knowledge with us. And we want to continue educating people about the mental health and its effect on the physical health, how important it is to take care of both. People, you visit the doctor definitely for a fever, dengue, malaria, all that is very well taken, diabetes and those kind of things. But mental health is one thing that people just neglect or push it aside till it gets too much. So I think treating it early uh, will definitely be a big help. Yeah, I think one more question is there. Sorry. Ninth standard student from Hyderabad is addicted to mobile phones and even stopped going to school. When the mother informs others for help, he threatens that he will commit suicide. Do you want to take that last one? I
Yeah,
just,
sure, ma'am.
yeah, yeah.
Nowadays, we see this quite commonly with cell phone screen addiction. So now this requires a lot of integrated treatment along with the mother and the child, first dealing with the child, asking them, what they are going through. We try to come to a middle ground where the child gets the phone for a certain period of time, but he has to fulfill his responsibilities. So his studies, his homework. If those things are completed, like a positive reinforcement, he can get his phone. And as far as the suicide threats go, yeah, we inform the family that not to keep any sharps, any other things, which he can do that. At times, I know it's still against the privacy, but if they can avoid putting locks in the children's doors, because sometimes that can also occur. So certain precautionary techniques, but a lot of counseling for the child and the mother is required for long term.
Yes. Thank you. That's helpful. We are planning to do something even for addictions in the coming days. Let's see how we
Yeah.
have our team members agreeing for that. Yeah, so please share your feedbacks. That will be really helpful. And I think Lavni has messaged you all regarding this session. So she will be keeping in touch. She's from our team. So she's coordinating all these sessions. So if you all can just keep in touch or save her number, she will keep you informed about future sessions. Yeah, Lavni has posted her mobile number. So I want to thank each one of you all for making it here. It was great to have you all here and for the interaction that you all had. We'll continue speaking about mental health. As much as we talk about physical health, we want to talk about mental health. Thank you, Dr. Suraj. Thank you very much. Thank you, each one of you all, for joining. Bye.
You so much. Bye bye.
Bye. Thank
Bye.
you. Thank you.
Thank you so much. Bye bye.
Yes.